We're very pleased to welcome you to New Jersey ACEP's third installment of the Leadership Development Series. Today, we're really excited to have with us Dr. Marc Milano to present on enhancing the ED experience for patients, providers, and families. He's currently the chair of the Department of Emergency Medicine, RWJUH Somerset, and the Chief Innovation Officer for the RWJUH Barnabas Emergency or EHM service line. Former New Jersey board member and has extremely extensive experience with patient experience. So I will turn it over to Dr. Marc Milano.
Thanks, Jessica, for the kind introduction. I hope I can live up to it. I also just would like to acknowledge New Jersey ACEP, the board of directors, the officers for thinking through something like this and putting it together. I think it's really critically important that we provide a pathway to leadership for our up and coming leaders and those latent leaders that haven't been identified yet. And I think one of the things that really should resonate with all of us is patient experience more and more. I think it's become something that's become a more distant thought in the last 18 months because of other competing priorities. But I'd argue that it's probably more important than ever to focus on that patient experience, because not only does it benefit the patient and their family, but I think most of us would agree that docs that have had traditionally high patient satisfaction or great patient experience scores are generally happier docs. So when you get all that put together, you create a great environment for care. So that's why I think it's so important to talk about this. And also the shoulders of the giants that I'm standing on who've already gone before me in this series, Dr. Pruden, who has proven himself to be an immortal of emergency medicine, literally, and Dr. Sacchetti, who is also a legend, at least in New Jersey, if not nationally, with all he's done to contribute to our specialty. So I'd like to thank them for paving the way for this as well. So people looking at this first slide might wonder, why do we have a picture of a big box home improvement store to start out a patient experience lecture? And I'll tell you that very personally, this hits me because I have always confessed to not be a do-it-yourselfer. I'm not very skilled at doing things around the house. My wife kind of jokes that, she does all of the heavy lifting and I go get the light bulbs. So, every so often I'll get sent to a big box home improvement store like this to go get light bulbs or a key made. And, I walk in and I'm ready to do what I've been appointed to do, except I don't exactly know what I'm doing. I don't even know where to look. And I see lots of folks running around frenetically with orange jumpsuits on or, the tape measure on their belt, and they clearly know what they're doing and where they're going, and they're having side conversations. And I'm walking around aimlessly trying to find that one item that I was sent there to get. And I walk through every aisle and I can't find it. And I'm hoping that someone's going to acknowledge me and say, can I help you? What do you need? And it doesn't happen. So I start to become distressed. And then after I'm there a while longer, I start to become angry. And then after a while, I become hopeless and I just want to walk out. And I guess what that means to me is what an emergency department, a hospital floor, a critical care unit looks like to a patient when they enter our facility, right? It looks like this big, intimidating situation in which people are running around, clearly knowing what they're doing, but not necessarily acknowledging them. And I think one of the most important things we need to do is to demystify the environment, make it more comfortable, make it more familiar, and make people feel like we actually care that they're there and what they're there for. So that's why I bring this slide up, because it reminds me when I need to show humility and when I need to become the one that's on the other side of the table, so to speak. So what is communication, which really is at the center of patient experience, isn't it? So, Webster does a great job of defining communication. And this is just lifted directly from Webster, which is the act or process of using words, sounds, signs, or behaviors to express or exchange information from your ideas to others or to a group of people like I am right now. I'm doing that. I'm communicating, aren't I? Would everybody agree that I'm communicating? I'm doing a good job, hopefully, of expressing myself, my feelings, my thoughts, my ideas. I think I am. And by Webster's definition, I'm doing a great job, except I think Webster really failed at something that is very germane to communication. And Webster missed this: listening. Listening is the biggest part of communication. And in our world, it probably should be 85 or 90% of the way we communicate is how we listen, how we use our body language, how we use facilitation to induce patients to share with us and to let them know that we're on their wavelength, because that's really how you get communication going. And that's how you improve the patient experience. So what are some of the easy things that we can do to improve communication or that sort of bi-directional sharing of information? Well, Facilitation is one of those important things, which is just letting the patient know that you want to know more about what they have to say. You want to get clarity on something. You want to ask a clarifying question. Tell me more about that. I need to know more in order to be helped. You also asking the patient's opinion sometimes is a very powerful thing, because the patient has insight and the patient may have done a little research. And I think many times, although we fear Dr. Google, we do want to know what the patient is most afraid of, right? We want to know why they came to the emergency department today. So asking them questions like, what do you think is causing the problem? Or what are your thoughts on this treatment? Right now, with all the new treatments we have, particularly with COVID, like monoclonal antibodies, it's really important to solicit that information, what their thoughts, what their fears are, and try to do as much as we can to dispel those fears so we can get them the treatment that they need. Obviously, listening without interruption can bend the perception of time, meaning that the longer you listen, that magnifies the amount of time the patient actually thinks you're listening. So if I listen intently for 2 minutes, the patient gets the impression that I was listening intently for 4 minutes, which again, just improves that connection that I'm making with them. And then the idea of the tell back. So wait a minute, let me make sure I got this straight. This started 3 days ago. It comes and goes. It's worse when you go up a flight of stairs, basically reflecting back what you've heard from the patient so that they can be certain that you listened and that you're willing to act upon what you heard from them. Other things that you can do is, emotionally responsive statements really resonate with patients. You look worried, something seems to be concerning you, or just facilitating through empathy. That must be tough for you. I'm concerned that this might happen in the future. And then one of the other things that really does resonate well with patients is showing them that you approve of them. It's very easy to sort of shake your head or your finger at somebody and say, well, if you didn't smoke, but rather than doing that, why not say, you're doing a good job with controlling your blood pressure, or I'm glad you came in today. And how many times have you as a provider had a patient apologize to you for coming into the emergency department when you came in and told them nothing was wrong? I get that a lot. When I come and say, I have great news, and that's how I lead off. That's one of the things I do when I'm done with my workup on a patient and everything is okay. I don't start with sort of a retelling of the visit. When I walk in the room, as soon as I make eye contact, I say, I have good news, and when I go through that good news, and I don't do it in a flippant way, I do that in a very, very genuine and meaningful way. A lot of times I'll have patients, well, I'm really sorry we bothered you with this. And I'm like, are you kidding? I don't always get the chance to give good news. And, this makes my day as much as it makes yours. So I'm really happy about this. And I'm glad you came in. And I also tell people, you're the reason I have a job. So I'm happy you came in, and you're sort of, not just rewarding them, but you're sort of acknowledging their intelligence for what they did. And that goes a long way. So as it pertains to the patient, obviously we've talked about some things, but what about the family? Or I should say, the support group that often accompanies patients. Now, again, of late, that hasn't been something we've seen a lot of because we limited visitation. But when and if that's something that returns, and I'm sure it will, you really do have to go back to understanding you do have to treat everyone in the room. You have to learn the relationships, never make assumptions. I think some on this lecture probably have heard my story that I did when I was a resident. I was in a room evaluating a middle-aged gentleman, probably about my age now, who was there for chest pain and was brought in by a very young female that was accompanying him, and went through my H&P, and he wasn't very forthcoming with information. So I got frustrated, and I turned to her and said, "So what is it really that you brought your dad in for today?" And I made two enemies at that very second because I assumed a relationship that clearly was not the case. They were not a son and a father and daughter. They were in a very different relationship than that. But again, it's important to try to get those relationships. So what kind of questions can you ask that are not offensive? Like, oh, are you husband and wife? We don't want to assume anything, right? So I just ask literally, how are you all related? And then they can share with me what they want to share. And that's a very simple, inviting way to get the information I need. And I engage the family in many ways, actually. I put the family to work. I teach them how to move the back of the stretcher. Actually, Steph Simmons, who I know Jess knows well, who is a real guru in patient experience, nationally for Envision Health, is someone who talked about, I teach them how to use things in the room. So that actually saves work for me later. So if it's just a matter of showing them how to move the back of the bed up and down for the patient's comfort, not only am I showing them that I'm concerned about their comfort, but I'm actually making less work for the tech, the nurse, or me when I'm walking by the room and somebody calls on and said, hey, we need your help. So these things are important. Or engage the family to encourage the patient to drink their CT contrast. And it makes them feel like they have a role, but yet it also makes my job easier. And always make sure you get the patient's consent before you start responding to the other people in the room. Is it okay if I address everyone? Because that's an important thing. You want to make sure the patient knows that you are focused on them. So, teamwork is another piece of it. Teamwork is critical in the emergency department. I don't think there's another area of the hospital. We're so ED centric. It's hard for us to give anybody credit for anything, but we typically think that, we are the consummate example of teamwork. And essentially what it is not just, taking great care of your patients, but it's taking great care of your coworkers. It's creating that environment that's positive so that everybody has the same sentiment about making patient experience better. I always say when I walk out of the room, you lucked out today. You have the best nurse in the emergency department. That is a white lie, right? It's okay to say that because they're all the best nurse, right? But doesn't it make the patient feel great? And also importantly, I think it makes the nurse feel great. It makes the nurse shine a little bit, puts a little bit of a smile on his or her face so that they can go forward, knowing that they've already been teed up to be a hero. So I think that's a really good thing to do because, again, it just promotes this positivity and collegiality that really does make the team work better and helps the patient. Also, as we think about patient experience, safety is a big part of that, right? And I'm not sure how many different institutions are represented here today in terms of their high reliability journey. But, as a RWJUH Health doctor, one of the things we started working on about 5 years ago was this so-called high reliability organization. And really just keep in mind the three central tenets, which is, don't harm me, which is what we promised to do when we graduated from medical school. Help me, which is something we promised to do when we graduated from medical school. And be nice to me, which isn't necessarily a promise we made, but it's a commitment we have to make. If you just approach every patient interaction with these three things in mind, you really, really can't lose. Okay. So what does the team approach look like in our department? What we like to do is try to align the provider team as much as possible. We know that we're all on random orbitals going in a million different directions, docs going one way, techs going another way, scribes going a different way, and the nurses going over there. But at the same time, the more we can align our care plan, the better. So when I can, and it's not always feasible, but if I can get in the room with the nurse, and now I've got a lot of our nurses caught on to trying to sort of watch for the physician going into the room and then kind of following the physician in. So now the patient only has to tell their story once. The patient only has to go through that, difficult or uncomfortable situation once. And we all know that we've gotten that question from the patient, well, didn't I just tell the last person that? Why are you asking me? There's obviously a delicate way of getting out of that when it happens, which is, I don't want to miss anything. It's critically important that I understand every single thing that's going on with you. So I apologize that I'll have to ask you to indulge me. But if I don't have to do that because the nurse and I got in the room together, I've saved time, I've been more efficient. Not only that, the nurse and I now are on the same page going forward with that patient's care because I'm sharing my plan with both of them at the same time. And that's huge, right? It also gives us an opportunity to cross-check each other, meaning if I missed something or I said something incorrectly, the nurse has a chance to correct me. So the more we try to align ourselves, and if you can't do that, which I would call the gold standard, then I think at very least the silver standard would be getting the nurse who takes care of that patient after you've evaluated the patient saying, okay, I just saw the patient in room 44. This is what I think is going on, and this is my plan. Why is that a good idea? Number one, the nurse knows the plan. Number two, when the nurse goes in the room and a new family member has magically appeared who wants to know what's going on, now the nurse is empowered to have that conversation, and it saves me time from getting called back into the room to explain something I just explained. Not that I would be upset if I had to do that, but I think it's important that all of our team members know exactly what's on our mind as much as possible. Many of you have a card attached to the back of your ID. I don't have my ID badge today, or I would proudly show my ADET card. Although I'm not always so proud of ADET because I think ADET missed a lot of things, and that's why I made it into SLADET, or you could call it ADET 2.0. I don't want the advisory board or Press Ganey or one of the large consortiums to sue me, so I'll try not to use their terminology too much. But regardless, I had to add the S and the L because I think they're that important, right? So ADET is great: acknowledge, introduce, duration, explanation, and thank you. Those things are great, right? But what does that have to do with listening? Nothing. So ADET misses what we just said was the most important part of the whole equation, which is listening. And we also talked about sitting being important, and sitting not only helps you take a load off, but it also enhances the perception of time. Now, I've seen estimates of this done anywhere from 1.6 up to 5. So basically, for every minute you spend, you get 1.6 to 5 minutes of perceived time in the patient's mind. So by sitting and not looking rushed, you get all this benefit. And obviously all that open body language, leaning in, not putting anything between you and the patient, like your clipboard or a computer, really having that open dialogue and that physical open space between you and the patient really makes a difference in terms of connecting with them, right? And of course, listening is really the cornerstone of all of this. And it really can upset people when they feel like they're not being listened to. When you're distracted, I mean, some distraction is obvious, right? You're checking your phone, you're looking at the football game on the TV on the wall. And some of the distraction is just you're thinking about something else and not the patient, which is why you really have to coach yourself into giving them your full attention and all of your energy during all that time. And obviously we listen with all different parts of our body. We listen with our ears, but our eyes and our body language are critical parts of that. And like I said, sitting and leaning forward is huge, obviously, and don't interrupt the patient. Let them articulate their story. In fact, studies have shown that by allowing the patient to articulate their story fully, as difficult as that is for impatient, obsessive compulsive people like us, it actually takes less time to get the information we need rather than stopping and continuously redirecting them, and just encourage them to share their story. And again, we talked about this already, sort of repeating back and just listening, and not trying to plan what you're going to say next, not trying to plan your next move, but just immersing yourself in that experience of trying to elicit everything you can from what that patient, again, by asking them the right questions. What do you think is going on? What is your greatest fear? What are you trying to accomplish from today's visit? And then again, of course, reading that back to them to make sure that they understand that you completely listened and understand what they're saying. Also acknowledge things. And those of us from New Jersey, which is everybody on this call, should probably know who this person is. So, acknowledge the situation, right? When there is an elephant in the room, do not let it stay behind the curtain. Bring it right out and say, I know you're upset because you waited a long time to be seen. I know you're upset because you had a bad interaction with the ultrasound tech. I know you're upset because this is the third time you've been here for this problem. So when you have that prescience, when you're fortunate enough to know that there's a problem, and most of the time, I don't walk into a room and find out. I have someone who's told me already, oh, that patient in room 40 is pretty lit up already. I know that what I should do best is acknowledge the problem and show them that I have a commitment to caring and fixing it as much as I can. And again, the idea is acknowledging everybody else. And like I said, what else? Acknowledge the situation. When you know what it is, don't let that elephant stay hiding behind the curtain. Just call it right out so you can do it. So what is the introduce piece? That's pretty easy. Your title and your role, obviously, Dr. Marc Milano, an emergency room doctor. But really, what am I here to do? I'm here to find out what's going on with you and help you get better. So introducing is more than just telling them your name and your title, your sort of rank and serial number. It's actually letting them know that I'm the one who's going to do everything that's going to help you get better or try to find out what's wrong. So I think that's very important. And also introducing your team members so that the folks know what their roles are as well, so they know what to expect from them, because so much stress can be alleviated by helping to create the proper expectations for an ED visit, letting them know what the roadmap to that visit is going to be. Obviously, duration is another thing from AIDED. And of course, this is an easy one. Always generously overestimate within reason. If your labs are running 45 minutes today, tell them, oh, I think your blood work will be back in about an hour. And if you get in 45 minutes, you look like a hero. If it's an hour and 10 minutes, well, you said about an hour. So I think we all know that already. But certainly don't fudge, because when you just make things up like, well, your MRI will probably get done in 2 hours. That's like, the second worst lie you can ever tell, right? Because, for anyone who's ever ordered an MRI in my ED, that's about a 9-hour deal. And I feel that it's a lot better to be upfront with the patient early on and let them know, because they may say, listen, I don't want to wait. Saying that now as opposed to saying that 7 hours from now is going to create a lot less frustration for both of us. So I think it's important. But we talk about time in the emergency department being a big determinant of patient experience. And it's not just the actual time on the clock, but it's the perceived time, right? How many times have you overheard a patient, oh, we were there for hours, or you've been at the gym and 2 people on the treadmill next to you saying, yeah, I took my son to the ER the other night. We were there for the whole night, right? Like, did you sleep over? Were you there the whole night? But regardless, the perception of time is what really matters. And we can do many, many things to bend that perception. And a few of those things are what we talked about before: listening well, sitting. But the other 2 things that I've sort of done, one of which I think is really helpful, is what I call the drive-by. And, after training in Newark, I certainly had my experience seeing drive-bys, but this is a different kind of drive-by. This is the kind of drive-by that a provider does. And the way that looks is if I'm going to see a quote unquote new patient, there's a new patient in the back corner of the ED and I have to walk past 20 rooms to get there, why not stop in very briefly, maybe not even enter the room, but check on an existing patient and know what you're going to say before you even say it. So what I like to do is just peek my head in the door, not cross the threshold, which means I don't even have to do hand hygiene, and just ask a simple pointed question like, are you doing okay drinking your contrast? Or do you need anything for pain or nausea? And they just got that one little bit of additional engagement with me. They know I haven't forgotten about them. It gives me a chance for real-time service recovery if I see a big frown on their face. And I think it just helps me to keep track of the department so that I kind of have a better idea of what's going on with each patient. So that idea of the drive-by, it's just a quick check-in, a simple pointed question with a yes or no answer, and then I move on and see the next patient. But that I think can help to shrink the perception of time. And then also the idea of thin slicing, which is more of an industrial principle. Many of us do it, but we haven't called it that before. The idea of if you have to see many patients at the beginning of a shift, as opposed to sort of seeing every single one of those patients to sort of completion, stop in, hey, you need an x-ray of your ankle. I'm Dr. Milano. We're going to go ahead and get that done. And then I'm going to come back and get the rest of the story. See somebody that may need a COVID swab. Well, hey, listen, we'll order the swab. I'll come back. We'll get more information. I'm going to order something for you right now for pain. But this sort of taking and then coming back and successfully layering on additional information, that idea of thin slicing, taking a little slice of each patient and then coming back and taking another slice. And I don't think that that's what you do for your whole shift, but at the beginning of a shift when you need to move quickly and see a bunch of patients in rapid fire sequence, that's a very good way to do that. And again, I'm sure some of us do that, but we may not have ever had a name for it. Well, that's called thin slicing. Explanation, again, sharing the game plan. One of the best way to decrease stress is to give as much predictive information as you can. So these are the things we're going to do. This is why we're going to do them. Also telling them who else might be involved. I'm going to ask the cardiologist. I'm going to ask the physical therapist to see you. So that person's not coming in for the first time. And one of the things I see folks do a lot is, we tend to like to set it and forget it in emergency medicine. I always said that the emergency physician's favorite kitchen appliance is the microwave, because it works fast. It always gets the job done in a predictable way. And you can sort of just turn the knob or punch in a few numbers and walk away till it's done, right? We love that. But what sometimes can happen as a result of that is that we can fail to close the loop. And a lot of times what happens is, we think we did everything we needed to do. We told the patient the game plan. We wrote the orders. We followed the results. We did our charting. We called the hospitals. We got them admitted. And then the hospital goes in the room, and that's the first time the patient finds out that they're being admitted. That's a fail, isn't it? So you really need to close the loop with the patient, let them know what factors are going to be happening to them, who's going to be involved and when. And I think that's a huge thing. And again, we can't talk enough about engaging the team. And then the thank you at the end of ADET is the idea of just thank you for trusting us with your care. Thank you for what you've done to get yourself to this point today in terms of trying to help yourself with this problem. And thank you for sharing some of the most uncomfortable, frightening things in your life with us today. Because isn't that what patients often come to the ED with? They think they have cancer. They think they're having a heart attack. And again, I like to flip that around and say, isn't it great news that you're not having your worst fear? But I only know what their worst fear is if I asked in the beginning, right? So that's an important thing. Can't talk about patient experience without talking about surveys, right? You can't really have a conversation about this without some of those maybe ugly realities of our job, right? But I would say that if I was in medical school or taking my boards and you gave me every single board question before I sat for the boards, I should get 100%, right? I would knock it out of the park. Well, when it comes to our surveys, more or less, depending on whether you use Press Ganey, ED CAPS, HCAPS, NRC Picker, whoever it is, they all ask the same kind of questions, right? So, and they all resonate with the themes we've just talked about. So communication, how often did the physicians communicate well? Did the doctors treat you with courtesy and respect? Did they listen, right? Aren't these the things we're talking about? So you already know the answers on the questions on the exam. If you know those things going into the room, there's no reason you should not get 100% in every case. And not every situation is the same, and some patients are more challenging than others. But, within 2 standard deviations of the behavioral mean, I think most of the time these things work and we can do really well with patients. So I would argue if we do them systematically, we're very likely to have a great experience for the patient. And again, that reflects back on us. So how do you treat patients with courtesy and respect? That's a survey question. Well, first of all, responding completely to questions and requests. That's just a matter of, hey, can you help me with this? Or again, can you move the back of the bed up? I'm not comfortable in this position. Or how about the ubiquitous, can you get me a pillow? I relish that. Get the water, get the pillow myself. It just helps me to engage the patient. They know I care. And frankly, it's sometimes faster for me to do it anyway, right, than finding someone else to do it. So I say, that's a great way to show that you concern about their comfort and showing courtesy and respect, obviously. And again, another thing we'll talk about a little bit later is the idea of reassurance, because that is another thing that's free and something that we should leverage as often as we can. We talked about listening carefully, the whole idea of sitting, leaning in, facilitating, making eye contact. And then the other thing about listening and engaging the patient is the 4 faces that you have to learn, okay? So going back to anatomy, back in medical school, there were 43 action units we learned about in the facial muscles. I probably didn't learn all of those. I probably missed that day. But regardless, that's a lot. But what that means is you can actually make over 10,000 different facial expressions, right? And of those 10,000, you really only need to know 4 of those to be great at this, okay? And we're going to go through them, and I hope you can see as I demonstrate, okay? So the first one is furrow your brow. Is everybody furrowing their brow? Okay. So what does that mean? That means I'm listening, right? So furrow your brow, right? Now furrow your brow and squint, okay? That means I have a migraine. No, that means I'm listening and I'm taking you seriously, okay? How about furrow your brow, squint, and bite your lip? I know this is a lot, but it becomes natural after a while. That means I'm listening, I'm taking you seriously, and now I'm thinking about your problem. I'm figuring out what's going on. And then the last one is, aha, I got it. I listened, I heard you, and now I know what we need to do to help figure this out. Okay, so those are the 4 faces. Practice them on your own in front of the mirror. They work. Okay, how else do we communicate well with patients? Well, we need to use plain English in our communications with patients. And again, our vernacular is very different. It is a foreign language in many ways to patients. And I know patients watch TV, they watch doctor shows like Chicago Hope and Grey's Anatomy, right? And we know that they understand the way doctors talk, like they talk about labs on this patient, but I still can't take that for granted. So I don't say we're going to get labs. I tell them we're going to do blood tests. I don't tell them they're getting nebulizer treatments. I not only tell them they're getting a breathing treatment, but I tell them what it's for, and I emulate what it looks like, okay? I tell them they're getting an x-ray, not a plain film. I talk about, admission, discharge, you're going home versus, disposition to ED observation or hospital observation, right? We need to make sure our language is very simple. And again, describing what a medication does rather than just telling name, like, so for instance, we're going to hang a gram of cefepime on you. Well, what does that mean, right? Like, where do you hang it? Like, what is it? What's it? I just say we're going to give you this really powerful antibiotic in the IV that's going to help treat your infection. Another thing that helps to enhance patient experience is the proper professional experience. And again, that isn't necessarily a hard and rigid thing. It's just however you look, it's looking sharp that way. So whether it's scrubs, they're tucked in, they're neatly pressed, whether it's business attire, either way, the idea is that you're making a good first impression, because we know that first impressions do last a long time. And in fact, according to Blink, Malcolm Gladwell's seminal work, people could form an opinion within 30 seconds that endures for months. And that was actually looked at with college students, that they formed a first impression in the first 30 seconds of the first class, that they 82% of the time was consistent with their impression of that professor at the end of the course. So that's a really big deal. So that gives you an idea. And you only get, so I guess when they say you only get one chance to make a first impression, that should really prove it to you and why it's so important. And then I have a list of things that I call sort of the subconscious needs of patients. And I like to call them the top 12, but there's a 13, and that one is kind of the bonus question at the end. But really, patients coming into the emergency department may not ask you for any of these things. Like if you look at them, are they going to come in and say, oh, I want control over my life, or I want a friendly reception, or I want you to be honest with me, right? They're not likely to say that, but aren't those the things that you want as a patient? If you're a patient, aren't those things you want from an organization that you're dealing with, an insurance company, a car dealership? Well, the honesty part of the car dealership probably goes out the window, but you understand what I'm saying. Essentially, these are the things that patients may not even know they want, that they really need. And control over their lives is a big one. We're not going to dwell on all of them because some of them are sort of self-evident, but control over their lives is important, because everything we do from the second the patient walks into the emergency department is to take control away, right? We hand them a gown and we put them on a stretcher in the hallway, and we tell them to get changed into this ill-fitting robe with their back exposed. And then we start doing worse things like poking them with needles, telling them to turn over so we can do an internal exam, right? So we need to do everything we can to try to restore control. And again, information is the best way to give control. So if we explain the why of what we're doing and we give them some ability to predict their fate during this time in their life, it gives them some of that control back. Achieving goals is an important one. We talked about that earlier with, what were you hoping to accomplish today? Is it that you want to get back to work? Is that you want to be able to hold your grandchild and that this tendonitis in your wrist is inhibiting you from doing that? But again, understanding what matters to them really helps you to focus on what the problem is and what the solution is going to be. Preservation of self-esteem is huge, obviously, and that's by showing respect and courtesy. Fair treatment is a big one right now, and it has been for a long time. I don't think it's any bigger now than it has been in a while, but patients are acutely aware of our stratified system in healthcare today, from self-pay to Medicaid to Medicare to private insurance, right? And patients do have preconceived notions about the treatment that they may be getting based upon their ability to pay, right? But we all went into emergency medicine with one of the greatest gifts ever, which is I don't need prior authorization. I don't need anyone's permission to do 99% of what I want to do. And I actually tell patients that, I don't look at your insurance. It doesn't matter to me. I just do what you need, and you're going to get what you need while you're here. And I tell them that, my most important job is to make sure you get the right amount of testing and treatment today. Nothing more, but absolutely nothing less. And I think that's a great way of assuring them that they're going to get fair treatment. Friendly reception, that's easy. Smile, 5 W's, who, what, why, when, where. Those are things that obviously patients need to know. And that's part of your initial evaluation where you're explaining what the roadmap to the visit is going to look like. Security, that's a big one too. Don't start calling out private information in the hallway. I mean, not only is that a HIPAA violation to get you in trouble, but it makes patients feel very insecure, and call that out too. That's another one of those elephants in the room. Listen, I know you're in the hallway and it's a really uncomfortable experience for you, but I'd rather have you here in the hallway than in the waiting room. At least we can get started with your testing and treatment. And that's one of those so-called sad but glad statements. So in a way, you're turning that frown upside down. Another one, obviously, which is a sense of belonging. You just need to strive for that. There's no way to say that you can give the patient a sense of belonging. There's nothing you can say. It's what you do. It's how you treat them over time that gives them a sense of belonging. But what you really are shooting for with that one is, don't you want that patient to come back and say, we had such a great experience here. We never came to Somerset before, but after the last visit we had, we could never think about going anywhere else. In fact, we used to go to hospital XYZ, and now this is the only place we're coming, or this is our hospital. My family's been coming to this hospital for generations, and this is where we feel safe. That's what we should be striving for, right? And then number 13 is not on here, but it's, and I won't torture you with a quiz question, but that idea of reassurance. That's so easy to do, right? We all know within the first 5 minutes if something is seriously wrong with a patient most of the time, right? Most of us or anybody who's been practicing more than a couple of years pretty much knows early on what that reflex in your psyche is telling you. This patient is okay, this patient's not okay. It's okay to share that. I don't think this is anything serious. I think you're going to be able to go home today. Reassurance is a very powerful thing. And again, it alleviates the patient's stress very early on and enhances the quality of your interactions, because we all know that stress impairs the quality of our interactions. I also think that, we all should be as brushed up on emotional intelligence as we possibly can, because that's a big part of success. And, I would argue that, if you had a team of providers, I see some folks on this call are leaders, most of which of the folks on this call are leaders. I don't think it really matters how high everyone in your department's IQ is, or their board scores, or where they trained. In fact, I'd rather have a team of folks with extremely high EQ than IQ. They're going to be easier to manage. They're going to have better interactions. They're going to have better patient experience scores, and my life is going to be a lot easier. So I hire for EQ because that is what matters. And what is it? We talk about it. Some people have a very good sense of it. Some people have a more vague sense of it. But the working definition that I've always used, and this is my definition, it's one's ability to rapidly, efficiently assess the needs, emotions, capabilities of another person or group of people, using that information in the context of what matters to me to derive a mutually beneficial outcome, or also known as situation awareness for interpersonal relationships. Really, that's what emotional intelligence boils down to. And, without reading a list of things, these are the basic 4 pieces of it. Self-awareness. How am I feeling? What are the forces acting on me? Self-management in the context of knowing that I had a rough night's sleep, or I had a fight with my spouse yesterday, or, a couple of bills are overdue. I'm going into work today. I have to manage those emotions. So I'm aware that those things are on my mind, but I have to check them at the door. That's what self-management is, right? Social awareness is reading the room, reading the environment, and knowing what others need and what is important to them. And then relationship management is all of the other stuff we talked about in terms of making sure that we're sensitive to what's going on with other people, asking questions, learning about them, and building those relationships in a meaningful way. So these are the 4 things that you need to master. And the good news is that emotional intelligence can develop over time, which is not like your traditional intelligence quotient, right? Most of us believe that your intelligence is genetically predetermined and firmly set by your late adolescence or early 20s. And that's about as smart as you're ever going to be in terms of your IQ. It doesn't go up when you get to be 30, 40, 50, 60 years old. However, your EQ can go up. And the reason that can happen is because of this wonderful thing called neuroplasticity that's been studied now for about 30 years. University of Iowa, some of the sort of founding folks of emotional intelligence started back then in the 90s looking at lesion studies, which are the gold standard for neuropsychology, whereas to look at areas of brain that have either been surgically removed, damaged by trauma, or stroke, and then looking at the deficits those individuals would have after losing those brain areas, and looking at how those might correlate with your personality, behaviors, et cetera. And what are the important areas? You really only need to remember a few, although there's lots of different parts of the brain. Really, the big ones are the amygdala and the frontal cortex. Those are really the areas, and they're like the good cop and the bad cop, right? The amygdala is the bad cop, and the frontal cortex, the higher centers, are the good cop. So you need to master the interaction between those things in order for things to work out well for us. And, we talk about getting triggered. Well, this is the trigger mechanism. When people talk about that triggered me, or I saw that person get triggered, it's the idea of letting your amygdala get hijacked. It's stimulants response arc. So you see something, you hear something, it creates a visceral response from the basal ganglia down and react in a negative way. Our fight or flight response gets triggered, as opposed to kicking that stimulus up to a higher center and processing it at a higher level and then responding in a much, much more effective way. So the idea is not to let your amygdala get hijacked. Well, first of all, what are the possible things that can hijack your amygdala? What are those triggers? I mean, a really busy shift can be a trigger, right? But these things, really common things, condescension or lack of respect, being treated unfairly, feeling unappreciated, feeling that you're not being listened to, feeling that you're being held to unrealistic expectations. Well, that's every day, right? So your amygdala is constantly at risk. So you really have to understand what your triggers are, know what your symptoms of your trigger are. What are those physical automatisms that you suffer? Are you getting butterflies in your stomach? Are you getting a facial twitch? Something that lets you know you're getting triggered, or is it just that churning of your stomach? But either way, it's realizing what it is, doing some deep breathing and disengaging from that situation, and trying to reason with yourself so that you understand that this isn't a real threat. Right? Because that whole fight or flight response was to help you escape the saber-toothed tiger, right? It wasn't to stop you from getting into a fight with the charge nurse, or it wasn't to protect you from that. So you have to go back to say, all right, I know that they just put 3 patients in my section, but it's not because they wanted to hurt me. It's because of the pressure that they were under. You know what I mean? So a lot of it is just reasoning yourself through these situations and realizing you're not a victim. You're just part of a very dynamic situation, and we all need to be flexible. So how do you develop your emotional intelligence? Well, first of all, you have to understand about neuroplasticity and this idea of neurogenesis. So, true or false, humans are born with the maximum number of brain cells that they're ever going to have, and we can only lose them as we get older. Is that true, or is that false? I'll save you that. It's actually false. So there are about 10,000 new stem cells that are formed within the brain every single day. And those cells are plastic. Those cells are stem cells. They can be differentiated and incorporated. And this slide is, I think, Lauren, we have this on the post test, right, for CME credit, or no? Because this is the only slide you have to memorize. I'm only kidding. I don't see anybody smiling, but that's okay. No, but anyhow, these fried eggs over here in the upper left-hand corner are these so-called stem cells. And these cells have the ability, like all stem cells, to differentiate into different types of neural cells. They can then migrate and then functionally incorporate into new circuitry. This is how you learn a new golf swing, right? This is how you learn to ride a bike when you're little. It's leveraging these stem cells to go out and become specialized cells and create new synapses and new formation of neural networks that allow that behavior to happen. So what you need to do is you need to train these cells, which then generate new, better behaviors. And this is how you foil your hijack. So essentially what you're doing is by successfully approximating the good behavior, you're leveraging that neuroplasticity to make that good behavior the default response. And that's really what you're looking to happen. And I'll give you a very quick example where this came to life for me. So early in my career, and Christy will remember, I was an attending at St. Joe's in Wayne, and that was a single coverage ED for the most part. So basically everything that happened that hit the fan came, right into your lap as an ED doc there. So, early in my career as a resident, they don't give you EKGs to sign from triage. So that was something that I was immune to as a resident. But now I'm an attending, I'm single coverage, and the techs are bringing me an EKG to sign every 4 minutes, right? And, I was overwhelmed by it. I'm like, okay, I have 3 phone calls coming in, the medic box is going off, the nurse is asking me to come see this critical patient, and you're sticking this pink piece of paper in front of my face right now. It's the last thing I want to see. It went from a mild nuisance to a severe annoyance to an ultimate almost degree of hostility that I started to display towards the people bringing these EKGs, to the point where after a while, I stopped seeing EKGs. And then I realized I had a really big problem, because that meant they were avoiding me. They were actually trying to get someone else to look at the EKG. And that meant that the patient care could suffer. So I realized I was in a crisis situation. I had to do something about it. So I had to understand what was attacking my amygdala. Then I had to decide that's not okay, and start looking at how I could successfully approximate the better behavior every one of those days, recruiting those stem cells to create that new circuit. So what I would do is I would turn to the tech and smile as hard as it was hard for me to do and say, okay. And then I would actually move toward the tech the next day. Maybe it took me a week to get to that point, and say, oh, okay. I got to the point now where I actually see a tech wheeling an EKG machine out of the room, and I just walk up to them. May not even be my patient, but I walk up and say, do you need me to sign that? I just need to borrow your pen because I left mine in the nursing station. But basically, I was able to foil the hijack and create a better behavior by leveraging this so-called neurogenesis. And then we'll sort of take us home with some of the okay, what's in it for me? Even if you don't buy it because it's the right thing to do, even if you don't buy it because it creates a better work environment, if you don't buy it because it gives you more career satisfaction, it helps you stay out of depositions. It helps you stop from being a defendant. And in fact, one of the most commonly cited reasons for people taking legal actions against physicians is failed communication. And so if nothing else convinces you that this is the right thing to do, and this has been studied, you can look these studies up, this is the real deal stuff. We know that communication is the #1 reason that patients will decide to take legal action or not take legal action against a physician. And one of the other things that was looked at was, what are some of the common best practices that help you stay out of the witness stand? And these are the 4. Educating the patient about what to expect in the flow of the visit. Well, we talked a lot about that, right? Used facilitations. Tell me more about that. I'm interested in hearing what you think about what's going on. Laughed and used humor more. That's good for you. It's good for them. And spent more time, or at least appeared to spend more time, right? We all talked about already the ability of being able to bend the perception of time, and body language is another one. This is a Harvard study that was done, I think it was late 90s, early 2000s. And it was really an interesting study where they took basically just the verbal content of speech. They removed pitch, they removed intonation, and they played these surgeons speaking to patients with this sort of filtering, so that they really just heard the words in a monotonous way, right? And what was able to be gleaned from that was that those who spoke in a louder, more aggressive, faster tone were much more likely to wind up in a lawsuit than those who didn't. It's a pretty fascinating study. Again, there's some YouTube videos about it I would highly recommend watching, because it really tells you that, it is the way you present yourself. It's not just what you say, but it's how you say it. And then, we'll finish up with the idea that, people often forget what you said and often what you did, but they'll never forget how you made them feel. And really, at the end of an ED visit, isn't that really what it's all about? Is, letting that patient walk away feeling like we listened, feeling like we cared, and feeling like they got what they needed from us. And with that, I thank you guys for your attention, and, time for any questions that you might have now.
We definitely want to thank you, Dr. Milano, for joining us. Anyone have any questions?
Hi, Dr. Milano, it's Dr. Baker. Thank you for your talk. I did have a question with, running a department and having different clinicians who have their own style. Would you say there's a time frame or a method that you use in sort of giving these skills to your providers in order to kind of help coach them? Because you'll probably get the patient complaints back, and some of it is, we don't always communicate clinically what a patient needs to hear in patient terminology. I'd like to know, like, detailing, like, how do you actually coach a provider in learning some of these emotional, intelligent, and communicative skills?
Well, Janice, we had coaching programs, as you know, with Envision. We had coaching programs before that with EMA, where we actually had, physician coaches that would go out like a golf coach or a tennis pro and actually be the fly on the wall, watching the interactions. Well, it starts with the director. Like, I own that at my site, and I always said, like, and Dr. May can tell you, we've never had an outside coach at Somerset come in to help coach our providers. We have great providers, but when someone's been struggling, that starts with me. So, I'm coming in on my day off to work with that provider directly if need be, so that I can troubleshoot the problem. You have to see it first and foremost. You can't just get feedback from other people, because that is a valuable part of it. But I think the biggest part is direct observation. And I think that's been shown in many cases to be an effective means of troubleshooting these kinds of problems and ultimately fixing them. So my advice to a leader would be, you need to get in the room with the patient and the provider and watch what's going on. And again, the first couple interactions, we all think about the Hawthorne effect and are they going to be on their best behavior? But after a while, if you do it enough, they let their guard down and some of those things start to come through, or you get that one difficult patient that exposes their quote unquote weaknesses and you start to figure out, okay, I think this is the problem. Also, just a compendium of feedback can help, asking the nurses who are a lot of times in the room with the provider, and the provider's not necessarily censoring themselves or monitoring themselves as much as they would be if you're in the room, right? So you can use surrogates to do that for you as well. But I have to be honest with you, it really does start with the leader at the site being willing to get in there, roll up their sleeves, and engage that provider directly, and be able to say, I would have done that differently. Like, that's not how I would have handled that situation. Now, this might not work for you, so we need to figure out what will work for you and your personality style. But I won't know that unless I see it. So my role has always been to get in the room and watch what's happening. I hope that answered the question. I know it was.
Oh, no, it did. Thank you. It definitely did. Definitely.
It's hard right now, guys. With the collective strain that everybody has. I don't think there's been a harder time to be an ED doc. I don't think there's been a harder time to be a leader in emergency medicine than in the last 18 months. And a lot of folks have been saying this statement. It keeps resonating in my mind that we're over COVID, but COVID isn't over us. And I don't know how much longer it's going to last, but it really, you have to support your team. And that means, Dr. May can tell you, I'll show up at 10 o'clock at night with a box of cookies or candy and just walk around handing it out. I'm known to put on yoga pants and crazy colors and walk around the department. I'm sure some of you have heard about that. But I think it's really important to just, you just got to put it all on the line. And then, of course, you have to take care of yourself, though. You have to try to get off as much as you can, do those things that you enjoy, exercise, spend time with your family, take a bike ride, whatever it is. But, never has it been more important to manage your department's stress. But then, of course, you have to manage your own.
We certainly have time for more questions if anyone has any. And Rashid, I saw your comment. I think
Yes.
that anyone, I think that your neurosynapses are definitely still intact and not sclerosing, but.
No, it's like I said, that's the one thing we can always fall back on is, you can't fix your IQ, but you can continue to work on your EQ throughout the entirety of your life. So we all should.
Well, I'm certainly a bit biased, but Dr. Milano is a great leader and it's a great talk. Thank you so much.
It's a pleasure. Thank you.